when this is finished.
What do you mean we're going to be? I am already.
Yeah. Well, look, for us, it's a godsend. It means we can go to a lot of things that would be much too far away for us to attend in person.
Yeah.
Well, I think we've got quite a number of us attending virtually at the moment, and I'm going to kick this meeting off. I want to say the very warmest welcome this afternoon. And it's a mild storm blowing outside over Bournemouth at the moment. The wind is just rustling the trees outside of my study here. But I wonder if you remember hearing about, even if you didn't experience, back in the year 2005, Hurricane Katrina in August 2005. I believe it began in Mississippi and it devastated that state right down to Tennessee. And one of the questions that doctors had to decide was who to evacuate first from hospitals that were left without power or running water as temperatures soared above 100 degrees Fahrenheit. And that is an example of which focuses our topic today. Prioritizing medical treatment with inevitably limited resources. What criteria do we use? And kind of lurking also in there, do we all have a right to health care? And if so, to what extent? So prioritizing medical treatment with limited resources, what criteria can you use? I'm delighted that we have with us today, amongst other panelists, Dr. Vanessa Heaslip, who is the Vice Principal of the School of Nursing at our universities. Vanessa, would you care to introduce yourself and give a first take, if you would, on how you would respond to this question?
Thanks very much, Ian. If you see me looking down, it's because I've wrote myself some little crib notes of things to consider. So my background, and my background's obviously going to influence what it is that I say, is that I am a nurse. I've been a nurse in the local area for over 25 years, but for the last 18 of that, I've worked at the university, working with student nurses who are wanting to train to be nurses, as well as nurses that are currently registered in continuing professional development courses. The other thing that really influences my response to this is my particular areas of research and my research focus, which really started through my background as a nurse, both working in a hospital, but predominantly as a district nurse, so seeing people in their own homes. So most of my research is in the fields of social exclusion and socially excluded groups. So I've worked with Gypsy Roma travellers, with the homeless, with offenders and prisoners, as well as individuals from Black and ethnic minority groups and how they access healthcare. So the nurse in me and the researcher in me may actually have different views with responding to this question. So I'm going to start with the nurse in me first. So the nurse in me recognises that we are now all living longer. We're living with much more complex chronic illness that 20 years ago or 30 years ago we would have died from. We have children surviving at a much earlier rate of birth, a much earlier state of premature birth than we ever did before. We've had a huge growth in the advances in medical technology. And so with that, living longer with much more complex chronic illness is more expensive. And that's the reality of that, because we're living for much longer periods than we were. And we have this publicly funded healthcare system. Because it's a publicly funded healthcare system, there are always debates about should we be increasing taxes to put more into the NHS. But by and large, the country and the population don't want to pay more money in taxes. And so there is a limited budget. And within that limited budget comes those difficult decisions as to what we do resource and what we don't resource. And for me, with my researcher hat on, that comes to those sorts of questions. So do we resource on the basis of mortality? So do we have what's going to keep us alive, and we resource that over and above other aspects? So do we prioritize one aspect of health, our physical health, and then ignore our mental health, our sociological health, our financial health, our social health? And that's really quite challenging. So if we went down that model, we wouldn't necessarily fund fertility treatment. But we know, for example, that if you have fertility issues, that has a massive impact on your psychological well-being. And should that not be as equally important as your physical health? And so how do we make those sorts of decisions? So if we don't do it on the basis of that aspect, do we base it on the greatest good for the greatest number? So do we focus on actually what's going to keep the greatest number of people alive? But if we focus on that aspect, then actually what we do is we exclude other people who may be within minority groups that have difficulties regarding their health and well-being. And so is that necessarily fair? So if we don't do it on that basis, do we do it on the basis of who shouts loudest? So who's got the biggest voice? And sometimes that does happen. You know, if we look, for example, around how much resources get raised for different charities, you're much more likely to get more funding in cancer charities than you are perhaps charities that Gareth works with individuals that are homeless or more marginalised on society. So is there some aspect of what is socially palatable towards the public? And that makes me uncomfortable, because I think there are individuals who are on the minority who actually will then never get a fair crack at the whip. And we know that minority groups, so people that are socially excluded, actually have the worst health outcomes. So if you're living on the street, for example, and somebody is homeless, then your life expectancy as a woman could be something like 46 years compared to 70 odd years if you live in a house. So actually, is that fair? Because actually nobody probably would choose to live off the street, or very few people choose to live off the street. They end up on the street because of circumstance, because of poverty, because of low education. And then the challenge what we have is that you have this societal movement. So if you're a child born in poverty, then the chances are your children are also going to be in poverty. And so it goes from generation to generation. So actually, where's the fairness in that? And so for me, I'd be uncomfortable if it's on measures of social desirability, because I don't think that's fair. For me, it's got to have an aspect of who needs health the most, and should those who need health the most actually be prioritised? And we're having this debate this morning around the COVID vaccine. So some people are saying, actually, because we've done it on an age basis, and that for a lot of people, actually that works well, because we know that older people are significantly going to have poorer health outcomes with COVID. But then there are debates this morning actually saying doing it on this colour blindness approach of age means that we're not addressing the BAME communities, who we also know, so the Black, Asian and ethnic minority communities, who we also know have poor health outcomes. So I recognise the nurse in me, that there are always going to be these issues of resourcing, and should it be a clinical decision? But we've also got to factor in some of these wider societal factors that impact upon health that individuals have very little control over. And so I'm afraid, Ian, I have no answers to you. I have mainly questions and concerns that I'd like us to debate.
That's great. Thank you, Vanessa. And as you've said, some of the you alluded to how some of the issues that you've helpfully focused in your first response, your question raising response to this question, are also focused in some of the questions that are very live issues at the moment around COVID, and what is health in COVID. And how do you balance finance, people being able to interact with each other socially, children being able to get to school and have education, and so on.
And if I could
Yeah.
just say, Ian, one of the things for me as a nurse, we tend to follow the World Health definition of health. And the World Health definition of health incorporates not only physical health, but it's psychological, it's social, it's societal. So for me, and it is a personal view, and I own it as a personal view, I don't believe that necessarily our physical health should take precedent over our psychological health or our social health. I think that's something that we've got to determine as an individuals. So for some people, and it's a huge debate with COVID at the moment with care homes, that some people are actually psychologically and socially being deprived from the people they love most in order to protect their physical health. But that also has health implications because it reduces one's health and well-being. And so, you know, it's a very challenging time, I feel.
It is, and as a parish priest, I see that elusive but to me essential thing, spiritual health, as stirred in to everything in a holistic way there. However, let me move on to our other panelist for today, another doctor. At the moment, Gareth Sherwood is working with vulnerable groups, as you've indicated, but you've also been in the front line in the past in medical care, have you not, Gareth? Over to you for you to once more, for the sake of anybody who hasn't been on board before, just give a quick thumbnail sketch of Gareth and your initial response, perhaps responding also to part of what Vanessa has been saying.
So, as Ian has said, my name's Gareth Sherwood. I'm originally a medical doctor by trade. I qualified in '99. I worked for 8 years in hospital medicine. I specialised in oncology, so I did a fair bit of palliative care as part of that specialism. During my kind of interim periods between jumping into charities and leaving medicine, I also studied medical ethics and medical law. So I've got a little bit of a kind of an education base on the topic today. And then beyond that, I've worked with vulnerable groups in various charitable sectors for many years now, within the church, outside of the church. And currently I'm the chief executive of the YMCA here, which means that I'm involved in supporting an organisation that's looking after vulnerable adults, vulnerable children, vulnerable families. And as well as that, I'm also a trustee of the Health Bus locally. So I'm involved specifically with healthcare delivery to the homeless and the homeless community, and that's been mentioned before. So to kind of give you some kind of framework to kind of hang your hat on, in the literature with medical ethics and resource allocation, you'll find two main camps of allocation of resources. You find the utilitarian camp, which is the kind of the ethical calculator of harm and benefit, as using a good and bad scenario. So minimize the harm, maximize the benefit, that's good. And then as it goes down and you end up with more harm and less benefit, then it becomes a kind of a less ethical decision. So that's called utilitarianism in very crude terms. And you find a concept called QALY, QALYs we call them, which I've mentioned actually in some previous these discussions, quality adjusted life year. And what it means is very simple. If you're fit and healthy and you're running around chasing after your children, then you are a 1 on the quality adjusted life year. In other words, if you have full health for a year, that's a 1. If you have some chronic conditions or an illness which is going to last for a period of time, then and it affects your health and your independence, then that results in a reduction of the quality adjusted life year score. So you might be a 0.7 or a 0.5 or a 0.3. And the relevance of this is that they use these quality adjusted life year scales when matched against the cost to get you up on the scale back to a 1. And it gives you a rough calculation of the value for money of any clinical intervention to improve your quality adjusted life year, your health. And so it's a very crude measure. The problem with the QALYs is that they tend to favour the fit and healthy that have got something that's reversible. And they also tend to favour those that have got a bit longer life. And so kind of the older you get, the more frail you get, the less worthwhile it is putting money into the old machine to keep the lights on. And so certainly working in palliative care, quality adjusted life years, they basically say palliative care is not worth doing. And so if you really take a very strict calculator to the thing, then bring in euthanasia, and because it's not worth looking after these people. And of course, that's horrendous to say something like that. But the flip side of it is quality adjusted life years then start to speak to, well, if we spend money in an ITU versus spending money on a breast cancer screening program, we'll save more lives and promote more life by doing the prevention work than we will to the kind of significant intervention work. And of course, that creates that counterbalance. So we're seeing this in COVID-19 because we are effectively favoring the vaccine towards those that if they get sick will cost far more. And so the prevention program is actually driving it. And it's an economic prevention program. It's not necessarily being done to need, which is what we're seeing with the comments Vanessa made about the Black and minority ethnic communities, where we should be driving in that direction. It's purely based on straight, simple calculation economics as to why we've done it in the way we've done it. So that's QALYs, and that's the utilitarian mechanism. And the other main one that you see in medical research ethics and medical ethics is the needs-based, which is where, it's simply put, us as human beings, we tend to throw the resources where we see the greatest need. And so that means if the child comes in with cancer, we throw the resources at the greatest need, the things that pull the heartstrings, the greatest need that we see in front of us. And, talking to groups in the health bus, and I had a budget meeting in the health bus before arriving here, so greater illustration. You throw resources at the greatest need, and actually you can get better economic benefits out the back end. So it doesn't mean that a needs-based approach doesn't result in good economics. So simple example would be, if you invest in homelessness healthcare support, you will prevent a homeless person from arriving in an A&E with a significant problem. The average cost to the NHS of somebody who is homeless turning up with a medical problem that requires admission is £8,000 per person. And the health bus prevents 300 admissions to accident and emergency a year, which means it technically saves the NHS a significant amount of money. We're talking about 2.4 million a year locally that it saves. And yet it costs about £100,000 to deliver that. So when you start looking at needs-based economics and healthcare provision, it is appropriate to think about it in terms of needs. And it doesn't mean that just because you focus on needs, you end up with more costs. But here's the flip side. I can put money into looking after somebody with dialysis machine. It's going to give them an extra 6 months of life. And for the same price, I can save 1,000 lives on a prevention scale. So when you start looking at it like that, needs-based creates challenges. You start asking, well, where should we plumb this money? And it really starts to get tricky when you start looking at procedures which are on the fringe of what you understand as a health benefit. And Vanessa alluded to that with the social, with the psychological and the mental aspects. So should we be spending money on operations in and cancer treatments to improve the quality and outcomes for people who've got cancer? Or should we allocate some of those resources for cosmetic surgery for people that are not happy with their appearance? And, what are we, and so you can see where the balance of this starts to get really tricky when we're trying to understand an individual's perspectives of their own needs versus a societal's perspective of allocation of resources for healthcare. And because we have a national health service, we are trying to do a fair and equitable treatment of all people for the benefit of those individuals and the culture and society. And it's where this utilitarian view of quality adjusted life years throws into competition with people's own personal identified needs and how we find the marrying of the two, because technically based in two different ethical frameworks. And that's where I'll finish for now and hand back to Ian. But that's medical ethics and resources in a nutshell for me.
That's great. Thanks, Gareth. And that feels like a good point at which we can throw it open to the audience. You've very helpfully there, Gareth, ended by polarizing the self-perceived need of the individual on the one hand So I perceive my own need as being far more urgent than anybody else's, of course, actually. But there is also, it sits within society and within the financial resources that potentially have to be used for everybody within society. Somebody else like to come in there? I'm looking at the row of faces. Yes, Martin.
About 40 years ago, I had a heart attack. I was taken to what was then Boscombe Hospital and admitted to the intensive care. The consultant said to me, well, we've got to get you well because we want to get you back to work and paying tax again. Now,
that was revealing.
The implication was that I, and of course a few others, were funding the National Health Service. And I don't know to this day whether he was serious or whether he was joking.
Yes, yes. Come in other people to the discussion. So that's Ruth. And then
Donald was first. But I think Donald was first.
Okay, that's very kind. You're holding back. Don, would you like to jump in?
I was just going to add in a few, well, an extra thought really, which I think Vanessa's touched on, and maybe Gareth did as well, that as well as funding health directly, there are other things we can fund which influence our state of health.
Yes.
So for instance, Gareth has alluded to housing, and if you improve, well, I think Vanessa did as well actually, if you improve access to good housing, that can have an effect on certain groups in the population. And another thing that we've all discovered through COVID, if we didn't know it before, is we all need access to good open space. And when I used to work in planning, there was, at the time I retired, there was increasing evidence from research that giving people access to open space improved mental health, if nothing else. And there was quite a movement to try and get some funding actually from the health authorities to improve access to open spaces and improve the quality of those open spaces, because similarly to Gareth's example of the bus, a bit of investment there had substantial knock-on effects elsewhere. So it's just another part of the jigsaw, and just to make it even more complicated, really.
Well, yes, and you're probably aware as a planner about, Don, of the significance of building play areas for children into housing developments, because the research shows, doesn't it, that when children can play together, it's not, as some who are very purpose-driven might think, oh, that's a waste of time. Let's get them learning things that are quantifiable and testable as soon as possible. A load of rubbish, actually, I believe, as an educationalist, because purposeful play is hugely essential, I believe, for children's developing social well-being. Vanessa, would you like to come back in there?
Yeah, I just wanted to go back on what Don was saying, because actually I absolutely agree with you. So one of the projects that I did last year was something called Human Henge. And so in the Human Henge project, what we were working was taking adults with long-standing mental health issues, significant mental health issues, and we did a 10-week program actually based at Stonehenge, and it was about linking to ancestors and linking to our cultural heritage around what people did in the Neolithic period, and it had significant. So I did the health research on that, and what we were able to identify was, for the participants, it had a significant health benefit. So actually where their mental health was at the beginning of the project and where it was at the end, it was significantly better. But not only was it significantly better at the end, up to, and we followed the participants up to a year later, it was still having benefits. And that was around that connections, that feeling a sense of belonging with other people, but also in the world in which we live. And I agree with Don that I think there needs to be much more investment in social prescribing schemes. You know, so if we look at, for example, one of the biggest factors influencing older people is social isolation if you live alone. And actually, if we were to proactively have much more investment in social prescribing schemes, we significantly reduce the levels of depression. And we also know that social isolation has a significant impact on dementia for older people. And so if we could readdress some of those resources for a preventative, proactive measure, I think we could have a bigger health impact. But going back to what Gareth says, from a quality of life adjusted years, it's not seen necessarily economically as productive or viable. And that's my concern with only focus on a physical health and to the exclusion of the other dimensions of health, which I think does have physical health impacts.
Yeah, we hosted in St. Peter's over a year ago. Gosh, everything's going to be over a year ago now, isn't it? Pretty much. Music for dementia. And it's been proven, I think, just how if you expose people to music and give them the chance to take it in, they'll begin tapping their feet to it to begin with. And some of them who haven't spoken for some time will begin singing. And it's a real form of rehabilitation. I mean, we had some people playing the organ in St. Peter's, and gradually a whole church, not a whole church full, but those who were there began to be much more lively and I think much healthier. Let's get others involved in the discussion again. Who else would like to come in? Gareth again?
Yeah, I was just going to pick up on that previous comment there from Don. I don't know if you've ever read about the Broad Street cholera outbreak. It's not a recent event. It was in Westminster in the 1800s, and there's a chap called John Snow who isn't the man from Game of Thrones. He was basically a physician at the time, and he was researching. He thought it was an airborne disease at the time, but he was convinced that it was somehow germs in the water, and ended up doing one of the very first double-blind trials. I probably did it accidentally, and finding out that it was the source was basically a water source within the city of Westminster, and the cholera was coming from an area, and treated it and saved hundreds of lives. I mean, 600 and something, 616, I think it was, people died in that cholera outbreak in Broad Street, and he saved countless more by effectively doing good engineering and prevention rather than trying to treat the disease in the first place. And so there is ample evidence out there to suggest that you get about a 10-to-1 return on investment doing prevention rather than trying to treat the cause. And so if we apply that to our kind of social issues that we have in our country, the average Class A substance misuser costs the NHS and the police £70,000 a year. So if you invest in prevention, there was a study done in the US, I'm trying to remember the name of it, and they effectively invested millions into a prevention program in the schools and saw a reduction in drug use at the back end in that bracket. And it was a 10-to-1 return on investment. I think it was called the DARE trial. And I tried to get something off the ground about 20 years ago in the UK, because I was doing some schools education work. And I couldn't get buy-in from the local authority. And the reason is very simple, that we have an allocation of resources and we look at the needs in front of us and we want to address the needs in front of us with that allocation of resources. But it's short-sighted, because if we address the root cause of the issue, we actually end up saving money in the long term. And the challenge we always have is sacrificing some of the need now to prevent more of the need in the future. And we're drawn towards the need, but we have to temper that. So going right away back to John Snow and his Broad Street cholera outbreak, here was a man that rather than treat the individual cases as a physician, he tried to find a way of preventing cases in the future. And because of his efforts, he saved more lives than if he would have just treated them one by one. And that's some of the challenge in the way that we allocate our resources, is we have to be willing to take the longer view sometimes, even if it's at the point of temporary sacrifice. But we can only do that with good sound evidence. And there's loads of it out there in sociology to say the health benefits in the elderly, for individuals, for young people, for the homeless, for all this stuff. But it's the willingness to make that short-term sacrifice for the long-term gain.
Thank you, Gareth. Ruth, and I apologise that you've been waiting for a bit of time there, Ruth.
That's all right. I mean, the corollary of Martin's comment about his doctor, who may or may not have been joking, was that if Martin had already been retired, or if he'd been unemployed, perhaps they would not have considered him worth saving. And unfortunately, as we age or become disabled, or God forbid we're born with difficulty, then perhaps we're already regarded as being less.
Anyone else going to come in there? Don.
Well, it's just a comment, because I had a heart valve replacement a few years ago, and I can remember sitting with the consultant, and he said, "What do you do?" I said, "I'm retired." "So what do you do in your retirement?" And as it happens, I'm involved in quite a lot of things, so I listed them off, and he just looked at the nurse and said, "Push him up the list, would you?"
God.
My worry about that is who is to decide what is a quality life? So for you were talking, Ian, just now around the music for dementia. There would be lots of people externally saying, well, these individuals have dementia, so they're not going to remember this, so why should we do it? Whereas the nurse in me and the human being in me says, well, actually, if somebody gets 5 minutes of joy from listening to music, then actually what you've done is you've improved their quality of their living. And that is equally as important for me personally as it is the quantity of the life in which we live. And I agree absolutely with Ruth. If we have individuals, for example, who are born with Down syndrome that may not have the economic productivity that somebody who isn't born with Down syndrome, who's to say that that life is any less valuable? Because actually, I think there's lots we could learn from people with disabilities around that sense of being in the world and feeling the world and experiencing the world, whereas often I think we're too busy doing to appreciate the beauty of the world in which we live. So for me, it's around who judges that quality, and that would be my concern.
That's very important, isn't it? Yeah, Gareth.
It's really interesting. If you go back to the Native American Indian culture, they used to view children that were born with Downs as blessed by the gods because they were capable of unconditional love.
But we know that in some of our homes for young people with disabilities, that they struggle to get the COVID vaccine and other kinds of medical treatment as well.
Let's bring David in, David Wheeler.
Yeah. Round about 20 years ago, I had some dental implants for which I had to pay myself. I've now got the option of going for false teeth or more dental implants. And my feeling is that at my age, it ain't worth it. Equally, because we do have private medicine in this country, I've got, 10 years ago, the doctors thought I would not be able to walk unaided without a stick after a cycle accident. I still do. Sorry. I still do. Sorry about that. But again, I could have a private operation for a knee replacement, which would certainly not, which would improve my mental and social health as well as my physical. But again, at this age, I'm choosing not to. If I was younger, I would.
Gareth?
Let me play with your heads a little bit. I remember when I was at medical school, we were given an ethical dilemma of you've got one bed in your intensive care unit, and you've got 2 people who have just arrived needing that bed that have come from the car accident. collision of two cars. One of the people in that car, one of the drivers, is a police officer with a family. The other driver is the joyrider that stole the car and was driving like a maniac, and the police officer actually chose to try and stop that car using his own vehicle to try and prevent more damage to the public. So the question is, who do you save and why?
Can I come in there, Gareth? I don't know if how many of you have recently. I watched. I can't remember the name of the film. It had Benedict Cumberbatch in, and he was presenting the life of the gentleman who actually against the enigma in the Second World War at Bletchley Park and saved thousands of lives. And what was interesting is he was a homosexual man, and at that time he then was identified as a criminal and was chemically castrated because at that time homosexuality was against the law. And you think, there's a man actually who saved thousands of lives, but actually would be identified as a criminal. And so I just add that just to make it more complex for you.
Alan Turing. Alan Turing.
Yes.
I think it was done by Benedict Cumberbatch. He did the film, and it was amazing. So I just add that to make it more.
Paul Hart.
I'd just like to say, I know what you're talking about, and I remember those times back in the 1950s, 60s, 70s when that would happen. But we have moved on from there. Homosexuality has now been legalized. You'd have to excuse my terminology, I'm not university. But we have come on, we've moved on since then. And another thing I'll add, I have a brother with Down syndrome. He's staying with the McIntyre Schools and Homes, and the whole home has been inoculated as well as the carers there. So I think that's very, very good.
Yes, it's I mean, one encounters these sort of prejudicial attitudes. How worth is found in all sorts of ways. Our oldest daughter, Catherine, is 32 now. She's profoundly deaf. And in her first few years, coming on for 30 years ago, Lucinda and I had quite a fight. It was primarily then with Surrey County Council where we were living, but that wasn't only so. To get beyond the, oh well, you know, you must accept general provision, which in Surrey didn't include any financial provision for those who were profoundly deaf, who needed the very expensive option of a residential school with, you know, for teaching signing. And they said, oh, well, we don't do that in Surrey. Surrey doesn't sign. Actually, what we have are support assistants and we'll give your daughter a hearing aid. I said, but we said, but we've tried that. It's proved that it doesn't work. And we had to make ourselves quite troublesome, really, in an awfully polite but persistent way, in order to get what we got, a place at the residential school for the deaf in Brighton. So yeah, that's an experience that I've had as well, as to how you gauge worth and how financial provision is worked out in terms of proper health and, in this case, education provision. So, who else is going to come in? Adrian.
I'd like to ask whether we are agreed that we should commit limitless resources to those who deliberately and repeatedly abuse themselves with alcohol, with drugs, with smoking. Should we go on indefinitely offering them limitless medical support?
Gareth.
So to give you an idea of where that might sit, let's think of liver transplant for somebody who's an alcoholic that's blasted their liver. That's the medical terminology. And so with liver transplantation, because these organs are so precious, there is actually a restriction that you need to be proving that you are not using alcohol on a consistent basis for a significant period of time. I believe it's 6 months before you qualify to remain on the transplant list and actually receive a transplant. And so there is a level of restriction already in existence to try and prevent over abuse of the situation. But you know, let's take, for example, I think it was George Best who got his liver and then went to drinking again. And so, how do you draw the line even when they behave themselves for a period of time, get what they want, and then go back again? And so I have great sympathy with that. And so for me, there's something wrong with our support systems and our social support systems if we're positioning people to have an inadequate level of support and feedback to maintain their personal discipline when it comes to the abuse of substances, or and I think where these start to blur into probably another ethical discussion is whether we should be treating certain types of addictions as criminal problems or medical problems, and that's where we start really stepping into a different approach to managing people with vulnerabilities and behavioural problems. And so to give you a framework, we have a number of people that we house. A significant portion have life-controlling issues that they cycle around and could qualify for those that have repeated patterns of behaviour, and why should we keep helping them in that quotation. However, the types of support, the types of environment, and the patience levels that you have with the tough love and continuing to support, actually you can get most of these people to a place of stability where they can engage in a meaningful way with the support that they're getting. And so it is possible that we are not measuring like with like when we start saying, well, somebody's got repeated issues, so I'm not going to help them anymore. Because I
also think, Gareth, where do you stop from that? If we look at obesity, for example, obesity is another, you could argue, is another form of addiction. And I have to say this as somebody who would be identified as being clinically obese myself, because I'm not very tall. And so when you're not very tall, it's very hard. I'm 5 foot. So I would be identified as clinically obese. And I'm not particularly large. So, where do we go with that around those sorts of aspects? And I have to say, from a nurse who did spend quite a few years in A&E, it's amazing how many accidents and injuries you get on a Sunday morning from football. So do we say that if you choose to go to football and you dislocate your knee or you break your ankle, well, you've chosen to take part in football, so should you be responsible for having broken your ankle? And so it's the challenge is how far do we go on that system? If we go into a blame culture, every one of us will make decisions, maybe poor decisions at times, around what we eat, and the impact that has long term on our health. And I think obesity is a big, if we're thinking about alcoholism, we've also got to think about obesity, because that actually probably costs more. If you link it to coronary heart disease, you link it to diabetes, you link it to stroke, you link it to heart attacks, it's probably a bigger issue because of how many more people we've got within society that are obese.
You're absolutely right. Obesity and diabetes will bankrupt the NHS if we don't deal with it.
I find myself very attracted to the approach of the charity Footprints, which focuses on mentoring recently released prisoners, so that you've got somebody who has had a degree of training and who themselves receive some support, who is going to hang in there and help to keep the person at a very particular stage of vulnerability, as of course you are when you're recently released from prison, and going to try to help to keep them taking any drugs, any medications that they need, keeping off the alcohol, keeping off the drugs, keeping into productive, getting into productive ways of using their time if they can. We've got about another 10 to 15 minutes left. Let's get as many people as possible involved in this really important discussion, actually.
Can I pose a question, Ian? How would people here think we should ration it? So what do they think we should use as the mechanism?
That'll cost you if you want us to answer.
I just think all life is valuable and we should do whatever we can to save all life. The main problem is the lack of finance in the NHS. If we could find a solution to that, then we wouldn't have a problem.
David?
I was going to say, ask, to what extent is it the adequately well off, shall I put it like that, who determine where the money is spent rather than the poor and the needy? And is that anti-Christian?
or is our NHS just overmanned? Do we have too many managers, too many administrators, not enough health?
Just for a nice controversial statistic, there are more managers than nurses in the NHS.
I believe you.
And that figure was passed, I think that ratio was passed about 3 or 4 years ago. And in the private sector, you will find 1 manager to 4 nurses. So there you go.
One of the things I speak to my students quite a bit about is when we're developing services, that actually we need to engage with the voices. And I think David is absolutely right. We've got to make sure that often the voices of people that come forward are people that are typically very comfortable, very well educated, because they're more confident to come forward. And I say to the students I'm working with, we need to make sure that we're including all voices, because actually they're the people receiving the services. They're the ones that are going to help it better. So how do we go out and get those voices for people that are perhaps not as confident or to be part of those groups?
Not just the loudest voices or the most strident ones, or those voices whose owners have learnt to be able to work the system, as it were, in their favour. Yeah.
Yeah, and I suppose if we're going to talk about minorities, you need to ask why will some groups not take the care that is offered? I mean, why do we have some your religious or ethnic groups that don't want the COVID vaccine when they can have it free of charge?
Gareth?
I think it's a very valid question. I think that's where you need that grassroots engagement that Vanessa is talking about, because you need your local leaders and your local champions that are able to, in a familiar way, help people understand the benefits. We're effectively talking about informed consent and making sure people have got the truth to make an informed decision. People are quite within their rights to refuse these things. But you're right. And I think one of the challenges of the COVID vaccine is, it's actually a conversation I have tomorrow, and I'm trying to see if I can get it worked in, is that those that are within the minority community that have uncertain immigration status are going to find it very difficult to access the vaccine because of concerns over registrations, etc. So I'm at the moment just seeing what I can do for that group and how I can pull some people together to get them identified without being identified and then get them vaccinated. And so these are the things that start to come in, and you've identified it, where particular groups have specific needs. And the only way you can deal with that is not at policy level. You can only deal with that at the grassroots level, where you've got to listen first and understand before you can respond.
And to amplify there, I'm aware from my experience in Bournemouth that some people with uncertain immigration status may have to live with the uncertainty of that status going on. I mean, there's one couple who come to my mind who had to live here for 10 years, still waiting for their status to be clarified. So it's not an easy thing by any means. Suzanne?
Yes, one thing that occurs to me is a problem caused by lack of education for some people, because they, and which also goes with poverty and being less well off, that they're not aware of how to feed themselves in the best way, and even if they are aware, they can't afford it. So that's one point. I think education could possibly help, but I don't know how we achieve it.
I mean, one of the
And also, as far as this subject is concerned, my initial reaction is, I'm so pleased that I don't have to make the decisions, and I really take my hat off to the people who do study this and take the decisions for us. So thank you to them.
Yeah. So your primary educational community is the family. Before ever children get to school, they get their most basic socializing and their induction into what's right, what's wrong, what are good, bad ways of behaving towards other people, valuing yourself and others at home. So where there are dysfunctional families, that gives children a very poor start. So I mean, that's where some of the work that your colleagues, Gareth, do with families is vital work, in a sense, to get to the problem further up the stream, as it were. Yeah. We've got about another 5 minutes to go, 7 minutes to go, just checking there. Anybody want to jump in with a comment before I ask Gareth and Vanessa to sum up in a few moments? We're going to be looking at a different aspect of health next week. Don, and then Ruth.
If Gareth will tell us the answer to the question he set, we might answer the question that Vanessa set.
What is the question you want answering?
The two guys coming in from the road accident.
Okay. Well, I controversially put my hand up instantly and said I'd save the policeman, and it resulted in furore in the room, because they said, "Well, you can't just make a judgment like that." And I'm thinking, well, of course I can, but you can't do it. You can't, and of course it's an impossible situation. There is no right answer, and that is the problem we're dealing with resource allocation. Is we only have limited resources, and there's no right answer. And if there's any helpful ethicist out there that I can drag in with a good quote, it's probably Dietrich Bonhoeffer, who once said, if there's no evidence of a good solution, then you're left with the lesser of the two evils. And we really are kind of sometimes in this dealing with that sort of question. And maybe that's the best way I can sum it up as well, Ian. If I'm summing up, that gives time for Vanessa, who I want to hear more of. So my summing up is that there's no easy answer, and we very much as medics, and I remember this time after time after time after time, we're really making the best of the least worst options, rather than actually choosing the best, because we couldn't afford the best, or we weren't capable of delivering the best. So our best was the least worst.
Very grateful to you, Gareth. Ruth, a quick one before we close with you in a moment, if we may, Vanessa. Ruth, I've seen your hand.
Thank you. I was just thinking about Suzanne's comment about food and learning to cook. And why is it that cheap junk food is cheaper than proper food? Perhaps before we even think about medical security, we have to think about food security.
We're in a situation, and we're very often going to be there in these forums, because we address the big questions and we don't expect there to be easy, instant, add water answers. But what we do together, and I'm really pleased that we've been doing it today, is sharpen our focus on those questions and listen to one another's insights. Vanessa, really grateful to you for being with us today. And I'm hoping that you're with us again next Wednesday, when we're going to go into some other aspects of health. Would you be kind enough to sum up for us your take on what we've kicked around, these rather big questions today?
I have to say thank you so much for inviting me. I've really enjoyed today, actually, just having a chat about some of the wider issues. I think, as Gareth says, there are no easy solutions. I think as we move forward, our expectations of health and healthcare are only going to increase. And so these decisions are going to be tougher in the future. I do think we have to take a long look about investment in much more upstream models of health that really look at keeping us healthy and well for longer from a preventative aspect, and that has to include the wider social determinants of health, education, housing, all of the areas that we've discussed today. And then we can have more investment in actually helping people to keep healthy and well. It will have longer term impacts. These difficult decisions are always going to be held, and I'm just grateful that often they're held in multidisciplinary teams. So actually it's not one voice, it's multiple perspectives, and usually the family are involved in part of those discussions, so they are included, they're not excluded. And I think that's vitally important, because they know their loved ones best. They know their past, they know what they like, they know what quality of life is for them. And I think we have to remember the quality and not just the quantity.
Thank you very much indeed. And next week, we're revisiting this big question of what is health, which we've looked at from a number of angles today. And the angle that we're looking at it from next week is what ethics apply to digital meetings. Of course, it's not just meetings, is it? There are lots of questions, and I'm hoping that we'll dig a little below the surface with at least some of them in terms of the ethics of a digital society. Ladies and gentlemen, really grateful to you for being with us today. These are important issues that we're looking at. Get your friends on board, because we could do with them bringing what they have to offer to the table as well, and getting their minds turning around. What is it to be healthy? But for today, I want to thank again Doctors Gareth Sherwood and Vanessa Heaslip for a really good discussion. Ladies and gentlemen, thank you very much, and I shall see you next week.